Hello, friends. Greetings from India. At the outset, I'd like to thank Dr. Samir for giving this opportunity. And today I'll be speaking to you about rigid bronchoscopy, diagnostic and therapeutic aspects, the indications and the challenges associated with this amazing procedure. So I don't have any disclosures to make. So we all know that when we go back to the history of rigid bronchoscopy, it all started in the year 1898 with Gustav Killian. He did the first rigid bronchoscopy to remove an aspirated bone from the right mainstem bronchus. And that's how the rigid bronchoscopy started. And he is rightly called as the father of bronchoscopy. So the point of putting this slide is to make you understand that rigid bronchoscopy started as an out of the box thinking. So basically, they had to use an esophagoscope to put it inside the airway to retrieve a foreign word. So when it comes to rigid bronchoscope, you need to be innovative. You need to choose the instruments which are needed for a particular procedure and depending upon the indication. Basically, this rigid bronchoscopy are nothing but a hollow metallic tube which are made of stainless steel. They range in length of about 40 centimeter and has got a diameter which varies between 9 to 13.5 millimeter with a barrel thickness of around 2 to 3 millimeter. The important thing about the rigid bronchoscope is that the distal tip is beveled, and this helps to prevent the trauma to the vocal cord while intubating. And if you see the assembly of the rigid bronchoscope, it has got a shaft and it has got a head. And in the head, you have got multiple attachments. So you can connect it to the ventilator. There is an accessory port which helps you to pass the instruments. And there is a main port through which you pass the illuminating telescope, or sometimes you may use a flexible bronchoscope to attain both illumination and to perform your procedures. And the picture onto your right hand side suggests there is a presence of a rigid telescope which is then connected to the light source. And this is how the head looks like. As I said to you before, the head consists of a port which is connecting for ventilator, and sometimes in certain cases you may use a conventional ventilator or sometimes even a jet ventilator. And the accessory port allows you to pass the suction tube, or in certain cases certain instruments like a balloon, and the main channel through which your illuminating telescope is passed. And what you need to understand is about the distal end of the rigid bronchoscope. So there are two different types of rigid scopes. One is called as a rigid tracheoscope. In the rigid tracheoscope, you don't have these fenestrating holes which are used for ventilation. But if you see a rigid barrel with the fenestrating holes at its distal end, then it suggests that it is a rigid bronchoscope. That means you can put it inside one bronchus and can simultaneously ventilate the other bronchus and the other lung. And the distal end is beveled, and this helps to prevent any trauma to the vocal cords while intubating. So this is how the rigid bronchoscopic intubation is done. Generally, the patient is placed in with the neck extended and supported, and then you pass your rigid bronchoscopic assembly. The first anatomical landmark which you'll see will be the uvula, and once you cross the uvula and go below, you will be able to see the epiglottis. And what you have to do is you have to bend your scope using your thumb as a fulcrum and make sure that you don't injure the incisors. And then you go below the epiglottis and then see the vocal cord. And the moment you see the vocal cord, you pass the rigid bronchoscope and use this bevel edge to lateralize the vocal cord and enter inside the glottis, and you position your rigid scope inside the airway. And this isn't a complicated procedure. It becomes quite simple as you start doing these procedures. And this is what I was saying about the lateralization of the vocal cord. Now I'll show how we really do the rigid bronchoscopic intubation. What I am showing you currently is the traditional way of rigid bronchoscopic intubation using the rigid telescope. So as you can see from here, I am using the 3-finger technique and I'm using my thumb as a fulcrum. And as I go inside, I make sure that I lateralize the vocal cord and enter inside. But of late, what we are doing is instead of using the rigid telescope, we use the same flexible bronchoscope as both for illumination. And the advantage of using a rigid flexible bronchoscope is that it also provides suction, therefore it prevents fogging. And as you can see from here, once I visualize vocal cord, uvula, I'm going and visualizing the epiglottis. Now I'm passing my bronchoscope below the epiglottis. And once I see the glottis, I lateralize the vocal cord with the help of the bevel. And then through corkscrew motion, I enter inside the trachea. And it has to be done gently, and you should make sure that you don't injure the upper airway, because once the upper airway becomes edematous, then it becomes quite difficult for you to perform the re-intubation. And once it is done, now you can see that I am packing up the upper airway so that there is no leakage of gas, and I am connecting them to a ventilator through the ventilator port. The major relative contraindications for performing the rigid bronchoscopy are uncontrolled coagulopathy, patients who require extremes of ventilator or oxygen demands, and tracheal obstruction with a novice operator. And there are certain complications which are bound to happen if you are not cautious in intubating, like injury to the teeth and the gums, the tracheal or the bronchial tears, and sometimes it can result in severe bleeding. But having said that, as you start doing it, you will realize that it's a very, very simple procedure, and all that it requires is a certain orientation to the anatomy of the upper airway as well as good observation skills, and you need to have enough practice before you start doing it on your own. And the major indications for using the rigid bronchoscopy, as we saw earlier, the era of rigid bronchoscopy started with the foreign body retrieval. Apart from that, it is also useful to achieve hemostasis and provide tamponade effect, relieve airway obstruction for tumors or intubation-related stenosis, facilitate the placement of the tracheal or the bronchial stents, and it also helps in performing endoluminal therapies like a laser, APC, or for using debriding instruments. And in certain cases, when the clots are very thick, you may use it for removing the clots in patients with hemoptysis. So one of the major areas where the rigid bronchoscopy has seen a resurgence is in the bronchoscopic management of malignant airway obstruction. Now I'll take you through a case and I'll make you understand how we in real time perform a rigid bronchoscopic intubation and perform a malignant airway deobstruction. So here, as you can see from here, initially I am intubating the patient with the help of a rigid bronchoscope. The first anatomical structure I am identifying is an uvula. And once I know that I have identified the uvula, now what I am doing is I'm going below and I'm able to see the epiglottis. And once I see the epiglottis, as you can see from here, I'm putting my pressure on the thumb. I'm using it as a fulcrum. And now I am seeing the glottis, I'm lateralizing the vocal cord, and through corkscrew motion, I'm entering inside the trachea. And once I enter the trachea, then what I will be doing now is I'll be packing up the oral cavity so that I don't want any leakage of the circuit. And now you can see my anesthetist in the PIP connecting this ventilator to the ventilator port of the rigid bronchoscopic head. And whenever we do a tumor debulking at our center, what we do is we put an accessory suction so that we make sure that any bleed that happens, the blood is aspirated and prevents the contamination of the underlying lung parenchyma. And the next important thing is what we are doing is we are placing an endobronchial blocker in the form of a Fogarty. So this is a Fogarty blocker which I am putting it so that when I am doing a tumor debulking, in case if there is any bleed, it helps in achieving certain amount of a tamponade. And once it is done, now you can see that my assistant is securing the Fogarty in place so that once I am out with the tumor, there will not this Fogarty will help in attaining a local hemostasis. So I am placing the Fogarty in place, and once the Fogarty is fixed in place, my assistant is checking whether it is performing. Now you can see there is a big vascular fleshy tumor which is arising from the right main bronchus. Once I know that I am going to deal with a highly vascular tumor, I need to make all precautions. So what I'm doing is I'm going to tilt my bed slightly to the right so that in case if any bleeding occurs, it spills onto the right side and it doesn't contaminate the normal left lung. In addition to this, I generally place the head end slightly down so that all the bleeding that comes to the trachea and can be sucked by the suction catheter, and it will not contaminate the underlying lung. And before I do a tumor debulking, I'm instilling certain amount of adrenaline, and sometimes we even give a cold saline to decrease the vascularity of the tumor. And since it is a polypoid tumor, what I'm doing now is called as an electrosurgical snaring. And the important point to note while doing an electrosurgical snaring is that the FiO2 requirement should be kept less than 0.4. Anything above 0.4 can make you prone to airway fire. So I make sure that I give a proper instruction and I set the watts in the electrosurgical units around 20 to 25. And once I am very sure that the anesthetist has kept the FiO2 less than 0.4 and the settings are perfectly made and my snare is checked, now I will be going for an electrosurgical snaring of the tumor. So now you can see that I am holding the electrosurgical snare in my hand, and now I am passing the electrosurgical snare through the working channel of a flexible bronchoscope. Just because it's a rigid bronchoscopy, you need not use all rigid instruments. You can use your rigid bronchoscopy as a conduit, and you can perform most of the procedures with a flexible bronchoscopy. And now you can see that I'll be passing the electrosurgical snare, and my assistant is holding the electrosurgical snare in place. And now you can see that the snare is coming out. And once the snare is come out, I again make sure with my anesthetist that the FiO2 is less than 0.4. And once it is done, now you can see that I'm passing the electrosurgical snare. And with the help of an electrosurgical snare, I am snaring this portion of a tumor. Now the tumor is completely kept inside the loop. And once the loop is made, I'm going to snare this tumor, and I'm giving instructions to my assistant that to slowly use this snare to cut this portion of a tumor. So now you can see that I'm activating the cut option in the electrosurgical probe, and I'm instructing my assistant to start slowly snaring this tumor as I am pulling inside the snare. So now you can see that the tumor is being snared with the help of an electrosurgical snare. And once the tumor is cut, you will be able to see that the vascularity of the tumor decreases, which means that it has got dislodged from the main tumor. And sometimes you can use a cryo, and sometimes even with a mere suctioning through your bronchoscope, you will be able to retrieve this tumor. Now you can see that the tumor is being retrieved just with a simple suction through the flexible bronchoscope. And once the tumor is retrieved, I go immediately inside to see if there is no significant bleeding and the balloon is intact. So this balloon ensures that no bleeding spills over to the normal lung. Thereby, I am able to maintain the oxygenation and the ventilation during the course of the procedure. Again, I go for a repeat snaring because the tumor was only partially snared. But if you notice this tumor is not a perfect tumor because it is an infiltrating tumor, and it is not only a polypoid tumor. So the idea of doing this tumor debulking is to obtain enough tissue for diagnosis. In this case, after the second snare, you can see that I am using the cryo instrument to retrieve this tumor. I make sure that the cryo does not hit the normal mucosa to avoid any sort of an airway bleed. Now the tumor is being removed with the help of the cryoprobe. And once this tumor is removed, now I go inside, I inspect the airway, and I make sure that the bleeding is hemostasis is achieved. And you can see there is a recanalization of an airway which has been obtained. I am able to recanalize the anterior subsegment and the posterior subsegment of the right upper lobe. But however, it is an infiltrative tumor which is arising from the apical subsegment of the right upper lobe. So the most of the indications of central airway tumor are to attain a functional efficacy, and you need not have a very good cosmetic outcome, but can still attain a functional efficacy, and that serves your purpose. So in this case, since I know that it is an infiltrative tumor which is arising, and since it is bleeding, what I am doing is called as a double Fogarty technique, where we have put one Fogarty through the accessory port, whereas we are using the other Fogarty to directly go and occlude the site of the bleeding. So this is a technique that we follow, the double Fogarty technique at our center, so that we make sure there is no contamination of airway spillage with the blood after the resection of the tumor. Now, once the tumor is completely removed, most of the tumor is removed, and I am able to attain a functional efficacy. Now, what I am going to do is I'm using an electrocautery tip, and in certain cases, you can even use an APC to attain the local site hemostasis, so that the tumor stops bleeding, and you are able to extubate this patient on table. So now you can see that I am passing the electrosurgical tip, and once the electrosurgical tip is passed, again I instruct my anesthetist to make sure that the FiO2 is less than 0.4. And now you can see that I'll be burning the residual tissue with the help of the electrosurgical tip, so that the chances of the recurrence of the tumor gets decreased. So here you can see that now I'm going to activate, and I'm going to char the base of the tumor, so that the tumor doesn't come back, at least to a certain extent, till the chemotherapy starts taking its effect. Now the tumor is completely charred, so that now I have attained almost near luminal patency, except that I am not able to salvage the apical segment of the right upper lobe, but I am able to salvage the right anterior subsegment and the posterior subsegment of the right upper lobe. And once it is done, now the patient will be extubated on table and will be discharged home the very same day. So in such cases of a malignant central airway tumor, your rigid bronchoscopy plays a vital role, because these tumors can be highly vascular and it can lead to significant bleeding. So all precautions has to be kept in place. So I'll just show you one another case of a metastatic intratracheal melanoma to show you how rigid bronchoscopy is generally done along with an airway stenting. For example, this patient present to us with a near respiratory arrest, and the patient is having almost like more than 95% occlusion of the proximal trachea by a metastatic intratracheal melanoma. In this case, unlike the previous case, it's not a polypoid growth. So what we are doing is we are directly going for a rigid bronchoscopic debulking, which means I'm using the same rigid bronchoscopic barrel, and through the corkscrew motion, I'm making sure that I'm doing the debulking of the tumor without the use of any electrosurgical snaring, because sometimes after snaring there can be torrential bleed and you may lose the airway. The advantage of using the rigid bronchoscopic debulking is that the rigid bronchoscope also provides a tamponade effect. So any bleeding that happens gets restricted, and you are able to safely do the procedure. So now once the tumor is completely debulked with the help of a rigid bronchoscopic coring or a debulking, the portion of the tumor is cut, and now I'll be retrieving this portion of the tumor with the help of a cryo instrument. Now you can see that I'm using the cryo probe to retrieve this resected tumor from the airway. And once this tumor is resected, now you will be able to say I'm able to recanalize the airway so that the ventilation gets secured. Once it is done, now I'm using the electrosurgical cautery to burn the tissue, but you can see that the tumor is an infiltrative tumor. So in the same setting, I'm using a self-expanding metallic stent. And the advantage of using a rigid is you can see the stent being deployed with the help of thin bronchoscope under direct vision. So now I am able to deploy the stent in place. And once the stent is deployed, now you can see that there is almost near complete recanalization of an airway in a patient who had more than 95% occlusion of the proximal trachea. And generally, these patients are extubated on table and discharged the very same day. And this is how your rigid bronchoscopy really plays an important role in malignant central airway obstruction as a part of a palliative treatment and for providing immediate symptomatic relief to this patient. Now you can see that the patient walking back home the very same day following rigid bronchoscopic tumor debulking and airway stenting. So one other area where the rigid bronchoscopy really plays an important role is in the benign central airway obstruction. For example, you can see this patient. This patient came to us with a post-tracheostomy tracheal stenosis. There was almost more than 90% occlusion of the trachea, and it is a complex tracheal stenosis. So initially what we are doing is we are using the electrosurgical instruments, knives, to make the electrosurgical incisions to open up this airway. These are little complicated procedures, and you need to do it very carefully, because if you are little wrong, you may cause a perforation of an airway. And once it is done, now you can see that through the rigid bronchoscope, I'm using it as a conduit to pass the CRE balloon, and I am dilating the stenotic segment. And then what we do is called as a serial mechanical dilation with the help of a rigid bronchoscope. Now you can see that initially I'm using a smaller size rigid barrel, and I'm doing a mechanical dilation. And once it is done and I'm able to have an enough lumen, I'm passing a much larger rigid tube of 12 size to attain a luminal patency. And once it is done, now you can see that I am inserting the silicone stent with the help of a stent deployer under real-time vision with the help of a rigid bronchoscope. So whenever you want to deploy a silicone stent for a benign tracheal airway stenosis, the only way you can do it with the help of a rigid bronchoscope, and your rigid bronchoscope really plays an important role in benign airway stenosis management. This is yet another patient where the patient was having a complete tracheal stenosis. This was selected as one of the best videos in the Bali World Congress of Bronchology and Interventional Pulmonology. And this is an extremely challenging case. So what I'm doing is initially I'm making the electrosurgical incisions with the help of an electrosurgical knife. Then I'm using a CRE balloon and I'm creating a track. And we are doing something called as a retrograde dilation to open up the airway. And once it is done, with the help of a rigid bronchoscope and rigid bronchoscopic forceps, I am placing a Montgomery T-tube, which is a form of a silicone stent with a tracheal limb. Now you can see once the Montgomery T-tube is placed, the patient is removed from the tracheostomy and is able to breathe and vocalize and discharge the very same day walking. And these stents are generally kept for a 6 months to 1 year period. And after 1 year period, we are removing this Montgomery T-tube. And now you can see there is a near complete recanalization of an airway. And this patient is almost around 6 to 8 months on follow-up, asymptomatic without a recurrence of stenosis. So in such cases of extremely complex tracheal stenosis, sometimes your rigid bronchoscopic interventions play a major role in providing a symptomatic relief and preventing the recurrence and getting a successful outcome of tracheal stenosis. Apart from that, this is yet another interesting case where there was a post-pneumonectomy stump blowout secondary to mucormycosis, and you can see there is no bronchial limb left, and there is an ICD which can be visualized through the infected pleura. So to prevent an aspiration of the contents from the infected pleura into the normal lung, we wanted to place a modified silicone voice stent. So what we are doing is we are using the rigid bronchoscopy as a conduit, and all silicone voice stents can be placed only with the help of a rigid bronchoscopic assembly. And now you can see under CM guidance, under real-time visualization, we are inserting the silicone voice stent. And once the silicone voice stent is placed, now you can see that the infected pleura is completely secluded from the normal lung. Thereby, it prevents the contamination of the normal lung with the infected content from the right-sided pleural cavity. So in certain cases of silicone voice stenting, rigid bronchoscopy comes to the rescue. But however, the major role is in the management of foreign body. For example, this patient had a dental screw which went inside during the time of a dental procedure, and now you can see that the dental screw has gone and got deeply impacted into the left lower lobe. Initially, we tried to remove it with a rat tooth forceps. We are not able to remove it because it got deeply impacted. We used a Fogarty balloon to dislodge it. We were not able to. We even passed a rigid bronchoscopic forceps. But the problem with this sort of cases, the rigid bronchoscopic forceps do not reach the periphery airways. Therefore, we were not able to retrieve it. But one thing we noticed in this foreign body was that the distal end of the screw was serrated. So we tried a rigid forceps, but unfortunately in this case we were not able to. And sometimes your rigid assembly can even start injuring the mucosa and cause bleeding. We also tried a Dormia basket to retrieve this foreign body. Still we couldn't, but luckily we were able to hold the serrated edge, and with the help of the corkscrew motion of the bronchoscope, we were able to slowly dislodge this foreign body from the airway. And once the foreign body is dislodged and it is disimpacted from the airway, now we are using the Dormia basket to hold it in place, and we are removing the assembly in total. So whenever you deal with a case of a sharp-ended foreign body or metallic foreign body where you feel there could be a possibility of a injury to the vocal cord while retrieval of the foreign body, you should be using a rigid bronchoscope to avoid airway damage. This is yet another very, very interesting case of foreign body. We had this young boy who has got a significant upper airway edema, and he was tracheostomized, and unfortunately the tracheostomy limb got dislodged. And when we did an upper airway bronchoscopy examination, you can see that the upper airway is completely edematous. We are not even able to see the vocal cord. It is completely edematous, but somehow we were able to visualize the foreign body. So what we did in this case is we didn't use the rigid bronchoscopic barrel. Rather, we opened up the tracheostomy stoma with the help of a retractor from our ENT colleagues, and we directly went inside. We passed the flexible bronchoscope through the rigid bronchoscopic forceps, and we directly went inside. So that the advantage is that when we pass a flexible bronchoscope as a light source, it also helps in providing suction, thereby preventing the fogging and as well as the lack of visualization because of secretions. Now you can see that I am able to pass the rigid bronchoscopic forceps loaded with a flexible bronchoscope. And once I go inside under real-time vision, I am able to hold this foreign body in place, and I will be retrieving this foreign body. The technical challenge in this case was we were not able to keep him off ventilation with not more than a minute. So it has to be a quick in and quick out. And luckily, we were able to retrieve this tracheostomy limb. Another major area where the rigid bronchoscopy really plays an important role is in the management of an hemopsis. As you can see from this case here, you have got a patient who has got a massive bleeding. So initially, we are using the cryo instruments to retrieve this clots from the airways. And once these clots are removed, now you will be seeing that there is an active oozing of blood from the airway. So we need to prevent the further oozing of the blood and hemopsis. So in this case, what we will be doing is we are going to go inside and place an endobronchial blocker in the form of a spigot. Now you can see that there is an active bleeding ongoing. So what I'm doing is I'm intubating this patient with the help of a rigid. Therefore, it provides me an easy access to pass my spigots and then place these spigots and occlude the site from where the bleeding is occurring. Now you can see that the spigots are being placed. And once these spigots are placed, now we put a glue over the spigot so that the spigot stays in place and the hemostasis is achieved, and later these spigots are removed. And the major area where the rigid bronchoscopy really plays an important role is in the transbronchial cryolung biopsies. So I'll be showing you how we do the transbronchial cryobiopsies. So we initially intubate this patient with the help of a rigid bronchoscope, and through the side port, we pass the endobronchial blocker in the form of a Fogarty channel, and it is also connected to a ventilator. and my bronchoscope passes through the main working channel. And once this Fogarty is passed, now the Fogarty is checked if it is there in the particular segment where we want it, and we are checking with the help of a assistant. He is checking it whether the Fogarty is functioning in place or not, is functioning or not. And once the Fogarty is passed, now you can see that I will be securing the position of the Fogarty with the help of a tape. And then what we do is we go inside with the help of a cryoprobe and take a biopsy. There are few centers who do not use a rigid for taking a transbronchial cryobiopsy, but we would strongly encourage to use a endobronchial blocker and if possible a rigid bronchoscope, because that ensures the safety of the procedure. Because there are many cases you may do it without bleeding, but there are certain cases where once you take a transbronchial cryobiopsy, it bleeds significantly, and your rigid plays a very important role in providing airway conduit to do further interventions. For example, in this case, we are using it under a C-arm, and then once we know that we are in a particular position from where we need to take a biopsy, we go inside and we take the cryobiopsy of this lung and we send it for testing. Now you can see that I am visualizing the position of my cryoprobe with the help of a C-arm. I make sure that I am away from the pleura. And once I know that I am away from the pleura, I am activating my cryoprobe. And you can see that I will be removing this entire assembly en bloc. And once the entire assembly is, now you can see that I am away from the pleura, I am freezing the tissue and I am removing it en bloc. And once I remove it from en bloc, now you can see that the Fogarty will be inflated so that the bleeding, whatever happens, gets restricted to that particular portion of the lung and does not contaminate. So your rigid bronchoscopy plays a very important role in the routine performance of your transbronchial cryobiopsy. This is yet another case which was a highly vascular tumor. So we went inside, we localized with the radial EBUS, and then we took a cryobiopsy, and we do all our cryo procedures, most of the cryo procedures with the help of a rigid bronchoscopy setup. And in this case, it turned out to be an adenocarcinoma. So this is our interventional pulmonology setup at Yashoda Hospital, Somajiguda, and we have offering for both international and national fellowship programs. And this is our skill lab where we train the candidates as well as we conduct academic programs. So if any one of you are interested, then we are more than happy to have you with us. And this is my mail ID. You can drop in a mail if you are interested in pursuing fellowship, even if you are a national or an international candidate. Thank you once again, Dr. Sami, for giving this opportunity.